So we start with the acute coronary syndrome. What happened? Suddenly he went. Okay. So we have discussed the cardiometabolic risk, atherosclerotic vulnerable block, pathogenesis of ACS, algorithms for ACS classification we have seen. Now we are entering into the core subject, the unstable angina, unSTEMI, and the STEMI today. This will be covered today, and be very attentive because very important topic that either for individuals or your family members or also for the patients. Okay, now this is the diagnosis of ACS, acute coronary syndrome, prevention and working diagnosis. First of all, you must have a working diagnosis that it could be a acute coronary syndrome. The first step would be to take an ECG. So once you take the ECG, you have no ST elevation and ST elevation. The thing going on inside is shown when there is no ST elevation, the lumen is not totally occluded. When you have ST elevation means the lumen is totally occluded by the thrombus. Okay. When it is no ST elevation, then what you have to do a biomarker, cardiac marker, troponin. If the troponin is normal, then it's unstable angina. Troponin is elevated, it is NSTEMI. Okay. And unstable angina treatment is different, and then NSTEMI treatment is different, and STMI treatment is different. That is why we require to know the difference. Now, let us see the triage. Person has got chest pain. There is a working diagnosis, suspicion of acute coronary syndrome. Take an ECG. Persistent ST elevation is there. It is STMI. No other questions asked. Straight away go for reperfusion. If the segment elevation is there, clinical suspicion is there, symptomatology is there, straight away you go for STMI. Of course, make the baseline measurements of blood pressure, oxygen, diabetes and all that you measure, but reperfusion should be the immediate priority. Suppose there are only ST abnormalities are there, but there is no typical ST elevation, or the ECG may be normal or undetermined. If the ECG is undetermined or the ST segment and T wave inversions abnormalities are there, then you do a trop test. Trop test you have the card test today. You don't have to even send the lab. You can keep in the bag, pocket, and then open and do a trop test also. Like, any pregnancy test or HIV test or like that. So the trop is positive. Now what happened? He has symptoms, he has ECG abnormalities, trop is positive. That means high risk patient. The other thing is, as trop is negative, and then ECG is determinate, and then the acute coronary symptoms are not due to the heart disease, a low risk patient. Suppose his trop is positive, STT abnormalities are there, it could be an STMI or unstable angina. For them, what you have to do, early invasive and conservative. If the symptoms regress and the trop is not very much elevated and only marginally elevated or negative, then you have to go for conservative treatment. Let's go for the next step. What are the causes of 5 causes of acute coronary syndrome? Thrombosis secondary to unstable angina, mechanical obstruction, dynamic obstruction or vasospasm, inflammation and infection, increased demand due to any reason. Now, what are the things I require? 3 steps. First is history and physical to make a working diagnosis of ACS. Second one is 12-lead ECG, and right ventricular infarction must also be thought of. And cardiac biomarkers must be done. Okay, what are the symptoms now? Occurring at the rest and prolonged or more than 20 minutes. If there is a pain of 1 minute or half a minute, it is not infarction. It could be only angina, but the pain should be more than 20 minutes. Rest angina or new onset angina. New onset angina of Canadian classification 3 or more frequent, longer and lower threshold. That is called the crescendo angina. That means it is becoming more frequent, it is duration is more, and little bit of exertion itself is causing angina, which is called the crescendo angina. Or patient may not have angina at all or pain at all. They may present with dyspnea in women and diabetics, in elderly people, in CKD and post-MI. In these 5 conditions, the typical chest pain may not be there. Who are they? Women, diabetics, old age people, CKD and post-MI. There's what is called dyspnea will be there. that is called angina equivalent. Look for angina or angina equivalent. Now, what are the symptoms? Classical symptoms. Central ischemic chest pain, impending doom, pain, heaviness in the arms, usually is the left arm, maybe either arm, elbow and finger. Discomfort in the neck, jaw, back, retrosternal, epigastric, sometimes dental pain also. Autonomic upset in the form of sweating, vomiting and nausea, particularly with inferior myocardial infarction. In general, if any pain above the umbilicus, you have to consider coronary disease. And signs, autonomic signs, increase in the heart rate, blood pressure, there may be a drop in blood pressure, sweating and pallor may be there, exacerbating factors like anemia, hypertension, cyanosis, fever, and signs of complications like LVF, arrhythmia, and hypotension. There may be murmur of aortic stenosis, HOCM, carotid bruit, and vascular disease. These are the signs. Now, ACS presentation for triage. How do I triage the patient? Very important. A person with chest pain or severe epigastric pain, non-traumatic. It should not be a traumatic chest pain. Traumatic chest pain, very rarely it is acute coronary syndrome. In origin, non-traumatic epigastric or chest pain, typical of myocardial ischemia or central substernal compressing sensation or crushing type of pain. Pressure, tightness, heaviness, cramping, burning. Unexplained indigestion, belching, and epigastric pain. What happened was one colleague of mine, he is a pediatrician, around 50 years when he was practicing, he had some chest pain and he ignored the chest pain thinking it is gastric trouble. Within 6 hours, he became gas. He died. So he went into the gas burner after 6 hours. So a physician himself is not able to take care, and he took some omeprazole and Digene and continued the practice. Had severe hypotension and died. So what to do? He was practicing opposite to my chamber in the same street. I am on this side and the other side. He didn't even call me when he had chest pain. Otherwise, I would have taken ECG in the morning itself. I would have died. When he is collapsing, then they called. Doctor is fainting. Doctor is dying. Not dying. He is fainted. Then I went, no pulse, no heart. What to do? And they're telling morning onwards, he's saying this. What foolishness it is. Okay? Dyspnea, diaphoresis, nausea, vomiting, epigastric pain. Elderly, in women, diabetic, CKD, post-MI, angina equivalents will be there. There may be a short notes for you on angina equivalents. What are angina equivalents? Dyspnea, unexplained sweating, nausea, vomiting, upper abdominal symptoms, particularly in the elderly, women, diabetic, CKD, post-MI. Okay, what do I do? Don't look for ECG or anything. Administer 325 milligrams of acetyl salicylic acid. That is available as sol aspirin, not the entry-coated aspirin. What you have to do is give soluble aspirin. All of you keep half a dozen tablets of soluble aspirin. If any person is having symptoms of acute coronary syndrome and the age group is relevant, then give him one tablet of 325 milligrams of soluble aspirin, nothing is lost. Then look for the ECG. In Western countries, they don't even look for an ECG. Immediately the person, the attendant himself or herself, they will administer 325. If not, the paramedic will administer 325 milligrams of aspirin. Then you will get a situation. I don't have soluble aspirin, but I have ecospirin. What is ecospirin? Same aspirin only. You powder it and the entry coating will go. 2 tablets of 150 milligrams of ecospirin. You powder and mix in water and drink. If soluble aspirin is available, good. Entry coated aspirin is not contraindicated. Only thing is it takes time for it to act, so break it and then mix 2 tablets and give it. This is the first thing you have to do. First of all, see whether the symptoms are commensurate with the diagnosis, working diagnosis of acute coronary syndrome. Look for angina equivalents if there is no typical pain. Then immediately, without looking this side or that side, no sublingual nitrogen or anything. First thing is 325 milligrams of aspirin. What every practitioner does, they will give isordil. That is not the first drug. You have to give 325 milligrams of aspirin. And studies have proved that in time 325 milligrams of aspirin has saved more lives than angioplasty and angiography. So we have got evidence for that. Now, what is the angina classes? CCS class. Canadian Cardiovascular Society classification. Angina with strenuous activity only, that is class 1. Angina with moderate activity, walking about 2 blocks or 1 stairs, 1 level of stairs. And 3 is angina with mild activity, walking less than 2 blocks or not climb a few stairs itself. And CCS 4, angina at rest and without much of activity. So you have to first of all see whether the pain is CCS 1 or 2 or 3 or 4. That is one assessment. Then also you should assess the Killip class, whether he has got any no signs of CHF, mortality 6%, class 1, S3 gallop is there, lung rates are there, 17% mortality. Yeah, class 3, pulmonary edema is there, 30 to 40% mortality. Cardiogenic shock, follow blood pressure, everything is manifest full-blown, 60 to 80% mortality. So CCS classification and Killip classification are very essential for prognostication. Now, what are the immediate steps? Clinical features, symptoms and signs suggestive of acute coronary syndrome. What should I do? Don't ask for help or telephone his father-in-law who is in USA and all that. Just give aspirin. I want to call his wife and take it. All that is later. Give aspirin first and try to reduce the pain in whatever way you want. Then look for an ECG, 12 lead ECG. ECG can be 3 types. One is ECG can be normal, ECG can have ST depression or T inversion, or ECG can have elevation, ST elevation, new onset LBB, or true posterior MI. So if the ECG is having ST elevation in 2 contiguous leads, more than 1 millimeter in the limb lead, more than 2 millimeter in the chest lead, 2 contiguous leads should show ST elevation, or new onset left bundle branch block. How do I know new onset? The previous ECGs are normal, fresh has got LBB, it is infarction. Or posterior myocardial infarction. I have shown you posterior MI is a mirror changes. It will be a mirror change than like the anterior. So that also you have to recognize. These 3 means STMI. Okay. ECG is normal, TROP is negative, it's not coronary artery disease. Consider alternative diagnosis. You are given aspirin, nothing happens. If it is not coronary artery disease, nothing. Okay, ST depression is there or T wave changes are there. Then you do a TROP. TROP is negative, unstable angina. TROP positive, NST. Now tell me, each one of you, what do you do? First thing, patient has come with chest pain, suggestive of acute coronary syndrome. What do you do first? Call her. No. Huh? Call him. No. Aspirin. 325 milligrams of aspirin stat. I don't have soluble aspirin. What do? Take ecospirin, crush it 2 tablets and give it. You have saved 50% of lives by doing that. Huh? Not the first one. First one is aspirin. That's what I'm telling. Don't look for ECG machine technician and all that. That battery not working, ECG technician not working, ECG technician gone for tea. All those things will not, they will not work. Give aspirin 320. Then look for ECG. If the ECG will have three answers. Typical ST elevation is there, or LBB is there, or true posterior myocardial infarction is there. It is ST segment elevation. No questions asked, immediate reperfusion. If he is not if he is in a center with angioplasty, they can do angiography, they can do angiogram and do the reperfusion. There is no facility like that. Immediately give teneliglipase, whatever is the reperfusion you have. Sorry. Okay, ECG is normal. There are no STT changes, though the symptoms are suggestive. I did it. Next step is to do a TROP. TROP is negative. Consider alternate diet. The third possibility is ST depression will be there or T wave changes are there. TROP is done. TROP is negative, unstable angina. TROP positive, NSTM. Why? ST-T wave changes are there. Symptoms are there. TROP positive, NSTM. Symptoms are there. ST-T changes are there. And no ST elevation. TROP negative, unstable angina. Okay. If the drop is normal, you should not discharge the patient. You have to keep him for 8 hours, repeat the drop. If the repeat drop also is negative, if there are no new changes in the ECG, if the patient symptoms have regressed, you can discharge him as non-cardiac diagnosis. This is the minimum algorithm all of you should know. Minimum algorithm. There are several things coming up now. STAT ECG and monitoring. Possible they connected to a monitor. ST segment depression of more than 5 millimeters and in 2 contiguous leads plus symptoms. Symmetric T inversions of more than 2 millimeters in 2 precordial leads. Don't go for T inversions in limb leads. They are not specific. Precordial lead T inversion is specific. If the patient is symptomatic, still you don't have the ECG changes expected, look for V7, V8, V9 also. Because initial diagnosis could be missed by not doing the extended leads. This is for left circumflex occlusion. Also, when the heart is rotated and lot of LVH is there, V5 may not show any changes. V5, V6, you do V7, V8, V9 also. Or, as I told you earlier, I had one Marwadi gentleman around 50 years. He came with typical symptoms of acute coronary syndrome. We gave aspirin. ECG was taken. ECG is normal. Then immediately we put the leads on the right side. V2R to V6R. Frank infarction is there. Either it could be right ventricular infarct or it could be dextrocardia also. Don't forget to examine the right leads and the extreme lateral leads if the ECG is not consistent with the patient's presentation. Continuous ECG monitoring is better. Normal ECG does not rule out acute coronary syndrome. Right? ECG changes might take time. Okay, normal ECG confirms coronary disease, but it cannot exclude coronary disease. If somebody has got new onset bundle branch block, it is same as acute coronary syndrome. Don't ignore new onset bundle branch block. Okay. Now, I have to risk stratify. Once I admitted the fellow, what sort of risk he is having, they will ask. What is the prognosis, doctor? How much risk is there? Low risk, medium risk, high risk. How do I classify? Normal ECG, flat or inverted T less than 1 millimeter, repeat ECG if normal, such a person is low risk. High risk fellow, transient ST elevation of more than 1 millimeter, deep T inversion, high risk. Medium, ST elevation less than 1 millimeter, T inversion more than 1 millimeter, then maybe a medium risk patient. If it is STMI, ST elevation is there, urgent treatment will be required. Now, what are the cardiac enzymes I have? 4 enzymes are there. Myoglobin, troponin, CKMB, troponin post-UA, unstable angina. You see the graph there. Myoglobin starts very early and then disappears within the first day itself, the yellow one. Next one is red. Drop also starts very early in 2 to 3 hours and continues for 6 to 7 days. CKMB also starts very early but drops after 2 days. Okay, so which will be the preferred test? Definitely drop because it starts early and continues for a long time. So I must do it. There are 2 types of troponins, trop I and trop T. Both are equally good. Trop I or trop T starts 3 to 6 hours, peaks in 24 hours, lasts for 15 days, very specific. CKMB starts in 2 to 6 hours, peaks in 18 hours, lasts for 1 to 2 days only, moderately specific. Myoglobin, non-specific. Don't do myoglobin. Trop I or T and CKMB. There is what is called the triple marker. We have to do. Every patient admitted must undergo triple markers. The first marker is trop I and T. Trop 2 is HSCRP. Trop 3 is your NT-proBNP or proBNP. What is triple marker? These 3 you have to do. Trop, HSCRP, NT-proBNP or proBNP. CKMB you may do or may not do. Myoglobin is useless. We don't do myoglobin nowadays. Earlier when trop was not there, myoglobin was done. Initial biomarkers are negative, Don't rub away the patient as normal. Every biomarkers will take time. Repeat the biomarkers after 8 hours. Okay. Now, depending on the drop, I have to classify the risk stratified. Low risk, medium risk, high risk. Low risk fellow, death 4.3%, medium risk 10.5%, high risk 16.1%. 5-month death. The low risk people, 5 months, in 5 months, 4.3 will die. In medium risk, 10.5. And in high risk, 16. What is low risk? Drop T less than 0.6 micrograms. 0.6 to 1.8 is medium, more than 1.8 is high risk. So not only the qualitative result of the drop, the quantitative result of the drop also is required. So you require the drop qualitative, you can do a bedside test, yes, no, then send it to the lab and get a quantitative estimate for the risk stratification. Now, other non-invasive tests, what else will be required other than that? What are the things you did till now? You summarize, what are the things you did? Yes, clinical, and then symptoms you have seen, clinical examination you have done, then you did the aspirin you gave, then did the ECG, then you did the drop, and then the other two markers also, CRP and then this one. Now you have to assess other important things. Pulmonary edema. How do I know that? Take a chest X-ray. 2D echocardiography. Why? Wall motion abnormalities, left ventricular function, left ventricular failure, left ventricular hypertrophy, aortic stenosis, which could be the cause of infarction, and hypertrophic cardiomyopathy, obstructive cardiomyopathy. So 2D echo is a must. Then anemia is poor prognosis. Low platelets, poor prognosis. High WBC, poor prognosis. You have to have anemia, platelets, and WBC. That means do a full CBC. Then renal function, thyroid function, electrolytes, and lipids also to assess the other risk factors. Of course, evaluation for diabetes goes without saying. Every patient admitted for coronary artery disease, we must know whether he is diabetic or not, what are the current sugar values, apart from the HbA1c. HbA1c is not going to be very helpful. Current sugar values should be noted. So one patient has come to me. He was a normal, he does not have any diabetes earlier. He had myocardial infarction. Immediately blood glucose is 250. That is not abnormal. So whenever there is a myocardial infarction, the hyperglycemia will be transient. So you have to look into the previous reports also. Now, cardiovascular causes. What is the differential diagnosis of symptoms simulating acute coronary syndrome? First one, STMI, ventricular arrhythmias, pericarditis also can have ST elevation and T wave changes. Syndrome X, aortic dissection, acute pain, chest pain, aortic dissection you must always consider. Respiratory causes, pulmonary embolism, pneumonia, acute ROAD, pneumothorax, pneumomediastinum. Gastrointestinal, epigastritis, esophageal spasms, hiatus hernia, GERD, peptic ulcer disease, biliary colic. Other causes, musculoskeletal, teeth syndrome, intercostal costochondritis, and then cervical spondylosis and psychogenic. So keep these things in mind. When the working diagnosis is not fitting, then you must think of alternative diagnosis. Now this slide beautifully describes the value of ST depression. No ST depression, you see, the mortality red one, minimum mortality in 180 days follow-up on the x-axis, you can see 90% or above are still surviving. And there is no ST depression. 1 millimeter depression and around 80% only are surviving. 2 millimeters depression, only 75% are surviving. That means ST segment depression is a marker of predictive value of prognosis. So unstable angina, NSTMI, risk classifications. Now, high risk classifications based on the troponin we have done, based on the risk factors also we have done, based on the ST segment depression we have done. Now, severe LV dysfunction, LVF more than 35%. Severe exercise LV dysfunction, LVEF less than 40%. 40%. High risk score on TMT, if you had a TMT earlier, the high risk score is there, negative score. And then perfusion defects on stress, echocardiography, anterior perfusion defects, echo evidence of regional wall motion abnormalities, stress echo, extensive ischemia. These are features of high risk. What is the intermediary risk? Moderate LV dysfunction, intermediate TMT scores, moderate perfusion defect in the ST on the stress test, and then limited W wall motion abnormalities on pharmacological stress testing with dobutamine. Okay, low risk, good LVF, low TMT scores, no perfusion defect, no wall motion abnormality. It is a low risk case. Now, another most important predictive variable is diabetes. The moment somebody tells me over phone that they have got an ST segment myocardial elevation patient with them, first question I put to them is, what is he a diabetic? He or she a diabetic? Why? Diabetics have double the mortality. You can see in hospital mortality, non-fatal MI, 1 year all-cause mortality, and mortality or MI, recurrent MI, everything is more, double almost in diabetics compared to non-diabetics. So it makes a lot of sense to know whether a patient is diabetic and control the diabetic. Now, unless, UA and NSTMI, risk factors, as I said, diabetes, hypertension, smoker, age, advancing age, dyslipidemia, family history, and previous CAD, all are risk factors for this coronary disease. TIMI risk score. This is a very important risk assessment you have to make. TIMI risk score for unstable angina or NSTMI. What is the age of the patient? More than 65. There are more than 3 cardiac risk factors. Stenosis more than 50%. ST elevation is there. Angina in 2 to 24 hours. He has got continued angina. Acetyl salicylic acid he has taken in less than 7 days. That means still he has got infarction. Means it is a higher risk. Increase in the biomarkers. 7 variables are there. So each one is 1 point. 0 point, 2 point, 3 points, 4 points, up to 7 points. People with 1 to 2 points, low risk, 3 to 4 points, medium risk, 5, 6, 7 points are high risk. What are the points? Age 65, more than 3 coronary risk factors, stenosis more than 50%, STDA upper and lower deviation, and then angina continuing, acetyl salicylic acid already taken, and biomarkers are positive. These are the TB risk scores. I'm showing you several types of risk assessments. KILIP risk assessment, Canadian risk assessment, TROP risk assessment, and then the ST segment risk assessment, diabetes risk assessment, and then TIMI risk assessment. All these are various risk assessments we have. Now you see, in-hospital mortality is correlating with elderly age, 1.7 for every 10 years after 50. KILIP class, 2 per class. If the class is increasing, the odds ratio will increase. Systolic blood pressure, 1 point is the odds ratio per every 20 millimeters. ST segment deviation, 2.4. Cardiac arrest during presentation, 4.3 odds ratio. Serum creatinine, 1.2 is the odds ratio for every 1 milligram increase in the serum creatinine. Positive initial cardiac biomarkers, 1.6 odds ratio. Heart rate, every 30 beats, 1.3 times. So this is how you have to make the risk assessment. Now, immediately patients will ask, patient's attendant, patient himself will ask, what is my prognosis? Doctor, you said I have heart attack. Do you think I will survive? What is the prognosis? How to predict it? Age, gender, diabetes, time lag for presentation, ST segment deviations, triple markers, LVH, ejection fraction, prior MI, whether aspirin taken or not, and whether he is a CKD or not. Diabetes and CKD are direct negative risk factors for coronary artery disease. Triple markers are also important. Age and gender also. Now, you see STEMI versus NSTEMI. So NSTEMI is comparatively, initially mortality is less. As you can see, STEMI, the mortality is more, the red line. But over a period of 15 months, What happens? STEMI and NSTEMI, they have almost the same mortality. Initially, STEMI is safer compared to NSTEMI, but as time passes, the both are equally cumulative mortality is same at the end of 15 months. Okay. Now, STEMI versus NSTEMI, hospital versus 1 year mortality. STEMI is the red one and STEMI is the blue one. You can see in hospital, STEMI more mortality compared to NSTEMI. Whereas 1 year mortality, NSTEMI is more mortality than the STEMI. That means don't rub off NSTEMI as a milder disease. That also requires lot of attention. So we have now done the various risk stratifications of unstable angina and this. Now I wanted to go into the treatment algorithms for unstable angina or NSTMI. Let us see that. So I'll read carefully. It is very easily visible because it's on the TV. Symptoms suggestive of acute coronary syndrome. Okay. Definite acute coronary syndrome features are there. ST elevation is there. Go to the right hand side, evaluate for reperfusion and follow the guidelines for ST elevation. So he has got symptoms, he has got definite ACS, there is ST elevation, reperfusion is the treatment, follow the treatment guidelines for reperfusion. Okay, he does not have ST elevation, no ST elevation. Then, due to non-diagnostic ECG, normal initial serum markers, there is ECG is normal, serum markers are initially normal, wait for 12 hours and observe for the symptoms. That is the strategy. Suppose he has got STT changes, ongoing pain is there, cardiac biomarkers are there, he deserves admission because he is NSTMI or unstable angina, managed by a acute ischemic pathway. Suppose he is initial ECG is normal, serum markers are normal, observe for 12 hours, recurrent ischemic pain, positive follow-up studies, drop became positive, diagnosis of AC is confirmed, treat him as though you have treated the fellow who had initial ST elevation and ST deviation and then the drop. Now, the other alternative is, this is a possible ACS. Now, chronic stable angina, there is no acute thing going on, but he has got crescendo angina, chronic stable angina, CSA, follow the angina guidelines. Non-cardiac diagnosis, treatment indicated by alternative diagnosis. If it is pleural effusion, you treat it. If it is some other cause, pneumonia or pulmonary embolism, treat the other causes. So non-cardiac, chronic stable angina, possible ACS, definite ACS. Definite ACS, ST elevation, no ST elevation, do the drop, and the no ST elevation, no drop, observe, repeat them. No recurrent pain, negative follow-up studies, stress test you have to do electively to provoke the ischemia. If the stress test is negative, non-ischemic diagnosis. If it is positive, then you have to do the treatment according to that. This is another basic algorithm. Now you look at this. Patient experiences chest pain and discomfort. Has the patient been previously prescribed nitroglycerine? That means, is he already a patient of coronary artery disease? Yes. Take one nitroglycerin dose sublingually. Now, if he is already prescribed nitroglycerin earlier, put isordil under the tongue sublingually. Is the chest discomfort pain improved or worsening after 5 minutes after treatment? Yes, it is improved. Then you have to call for it is worsening. Yes, it is worsening. Call immediately for the emergency service. No, it is not worsening and it has improved after the nitroglycerin. If patient is with CSA, if symptoms are significantly improved after one nitroglycerin, repeat the nitroglycerin every 5 minutes for a total of 3 doses and call for the EMS if symptoms are continued. Okay. Now the other way around. Patient has chest discomfort, pain unimproved, and patient never was prescribed earlier and pain is worsening after 5 minutes. Now, yes, you call EMS. And if it is not having any symptoms, then notify the treating physician. This is basically to say that if the patient is already on nitroglycerin earlier, you have to repeat the dose 2 or 3 times until the pain subsides. Okay, now Algorithm for patients with unstable angina managed by initial invasive therapy. That means we have decided to invade, do some angioplasty or angiography, that is initial invasive therapy. Diagnosis of unstable angina, unstemy is likely or definite. ASA, acetyl salicylic acid, you have already given. Then give clopidogrel if ASA is intolerant to start with. Then the management strategy is proceed with an initial conservative strategy and initial invasive strategy. Now we have chosen the invasive strategy, initial anticoagulation must be given. So what did we give already? We gave aspirin, we gave clopidogrel, now we are giving anticoagulation. What anticoagulant? Enoxaparin or unfractionated heparin or beviluridine or fondaparinux. Any one of the four agents, preferably enoxaparin. So if prior angiography was done, initial at least one of these things should have been given. Clopidogrel, GPG, the fourth one is the G2B3A inhibitor has to be given. Factors favoring admission of both clopidogrel and G2B3A inhibitors are delay to angiography, high risk features, recurrent early ischemic discomfort. Proceed to diagnostic angiography. What did I do? I diagnosed unstable angina or NSTMI, gave aspirin, gave clopidogrel, added anticoagulation, and going for invasion, that is angioplasty and angiography. Then I have to give them GP2B3A inhibitors, glycoprotein 2B3A inhibitors. We have 4 drugs there. I'll show you in the next slide. And eptifibatide, tirafibon, F60 are there. No, one of those you have to give. Every patient who is going for elective PCI, emergency PCI, must receive GP2B3A inhibitor also. Now, how many drugs are there? Aspirin, clopidogrel, enoxaparin, G2B. 4 drugs. So we are given aspirin before taking ECG itself. Then we added the clopidogrel. Then we added the enoxaparin. That is the anticoagulation. Now we have, because we are going for the cath lab, we have to give 2B3A inhibitors. Okay. Now, algorithm for managed for initial conservative. If there is no angiography at that hospital, then what you do? You will not give 2B3A and 2A3B inhibitors anymore. You have to manage conservatively. What do? Clopidogrel, aspirin, and then management strategy is conservative strategy, initial anticoagulation, enoxaparin, unfractionated heparin, fondaparinux. Initial clopidogrel, consider adding eptifibatide or tirafibon if you consider doing an angioplasty. The next one. Any subsequent events necessitating angiography? Yes. Then automatically he will proceed to the diagnostic angiography. No, there are no subsequent events, and we are deciding on the conservative treatment. Then evaluate the LVF, and LVF is less than 40, then go for the angiography. LVF is more than 40, then submit for the stress test because it is unstable angina. And then if the stress test is a low score, then of course you go for all the 4 drugs. If it is not low score, then proceed immediately for the angiography. Now, management after the diagnostic angiography in patients with unstable. Okay, you did angiogram. So you chose the invasive treatment and did an angiogram. It can show the results in the following way. Post-angiography management strategy. What are the 3 strategies? I can do bypass surgery. I can do angioplasty. I can give medical treatment. One of the 3 options. When do I choose medical treatment? No significant obstructive CAD on angiography. Optimal medical treatment, OMT you give. Antiplatelet and anticoagulation have to be continued. Antiplatelets already, double antiplatelets you have given, aspirin, clopidogrel, anticoagulant, depending on the discretion, you have to continue or not. Then CAD is there on angiography. So patient had CAD, the significant stenosis is there, then decided for against CABG or PCI. Then what I have to do? Continue aspirin, low dose clopidogrel, discontinue G2B3A because I'm not going to do any procedure, and continue unfractionated heparin, and then either the unfractionated heparin or conventional heparin. So this is the medical therapy with angiography without plasty. Now, I have done the angiography and decided to do a plasty. That is PCI, primary coronary intervention. PCI means primary coronary intervention. Continue ASA, aspirin, low dose clopidogrel, and then G2B3A we have to give because PCI is taken, and then discontinue anticoagulants after the PCI. No more anticoagulation after the PCI, but just continue the aspirin and clopidogrel. You have stented and the whole flow is restored. No, this patient is not suitable for medical treatment nor the PCI angioplasty. He has to undergo CABG. What do I do? Continue aspirin, clopidogrel, G2B3 inhibitors, and continue unfractionated heparin until you decide on the surgery. The moment you decide on the surgery, you stop the anticoagulation and the support of these drugs. So this is the after the angiography. So before angiography, conservative and then immediate invasive. Conservative I have shown, immediate invasive means go for angiography. Angiography results, optimum medical treatment, PCI or CABG. Which one I will choose? Now, revascularization strategy, what should I do? Cardiac cath lab we have taken. CAD is, wanted to look for, there is no CAD, discharge from the protocol. Cath lab said there is no significant stenosis. That means he is not in the revascularization strategy. No, CAD is there, more than 75% stenosis is there in one or more vessels. Is it left main disease? If it is left main disease, yes, CABG is the answer. No, it is not left main. It is in the circumflex, or it is in the right coronary, or in the distal branches of the LAD, and not in the left main. Disease is there, but it is not in the left main. Then one or two vessel disease, medical treatment, PCI, CABG, depending on this one. Three vessel disease, proximal LAD involvement, LV dysfunction is there, patient is already being treated for diabetes, yes, CABG. No, PCI or CABG. Do you understand? What do you do? Cath lab, you have taken the patient. Cath lab has showed CAD negative. Negative means less than 50% stenosis. Flow is good. No more continuation in the revascularization. CAD is positive. That means between 50 to 75% or more than 75% stenosis is there. Is there left main disease? There is no left main disease. Then go down. If it is left main disease, CAB is the answer. Left main disease, today they are doing stenting. A lot of cardiologists prefer. Even for left main also they are attempting stenting. But studies have shown till date that CABG is a better option than coronary stenting. Okay, there is no left main disease. 1 to 2 vessels only are affected. Optimum medical management, PCI or CABG. Any one of them electively you can. 3 to 2 vessels are involved. LV dysfunction now I look at. If the LV dysfunction is there or diabetes is there, one of them is there, LV dysfunction or diabetes, CABG is the answer. If there is no LV dysfunction, no diabetes, either PCI or CAG. There are conflicting reports related to these people who have LV dysfunction but no diabetes, or they have diabetes but no LV dysfunction. How to manage? PCI today is as good as CABG. Okay, now look at the long-term anti-thrombotic treatment. How many days I have to continue the anti-thrombotic treatment while I am discharging the patient? It's very important for you to know how long you continue the anti-thrombotic, antiplatelet treatment. Unstable angina, anesthesia, patients groups at discharge. Medical treatment without stent. He had optimum medical treatment, no stent is put. Or bare metal stent is put. Or DELS is put, drug-eluted stent. So no stent put, bare metal stent, drug-eluted stent. Depending on that, the anticoagulation. Bare medical stent, medical treatment without any stenting, aspirin you have to continue indefinitely. Clopidogrel at least 1 month and maybe up to 1 year. Double antiplatelet for 1 month, maybe for 1 year. Aspirin, lifelong, unless there is a bleed or contract. Okay, bare metal stent, double dose aspirin I have to give. 75 milligrams is not sufficient. I have to give 160 to 325 at least 1 month. Then continue 75 to 162 indefinitely. Clopidogrel for 1 month and maybe up to 1 year. So here the difference between the previous one and this one is the dose of aspirin is double. And that is instead of 75 to 162, I give 160 to 325. Drug-eluted stent, we must give 160 to 325 at least 3 to 6 months, then reduce it to 75 to 162. Clopidogrel for 1 year you must give because you have given drug-eluted stent. So if you have done a procedure without stenting, only angiography you have done and angioplasty you have done, you have dilated the vessel but not put a stent. Bare metal stent, drug-eluted stent. Depending on that, is there an indication for anticoagulation? Any other indication? Any like atrial fibrillation or anything? If yes, warfare. If no, continue the dual antiplatelet therapy. This is to manage the antithrombotic treatment after discharge once you have done the stenting. Stenting or no stenting. Angioplasty is done, stenting is put, no stenting is done. Like that. Now, initial medical treatment for unstable angina. What I have to give? Already 325 milligrams aspirin you have given. Beta blocker, particularly metoprolol, is very useful. 5 milligrams, 3 times or 25 milligrams. QID oral. IV means 5 mg 3 times. Okay, nitroglycerin you can give. Heparin 4000 international units or 12 units per kilogram. Morphine for pain relief, epomorphine or morphine, and then oxygen. Now, TIMI score based management. TIMI score can be 0 to 7. I have given you the table, age and all those factors are there. It could be as much as low as 0 or as high as 7. Then as you see the green bar here, it's increasing. Beta blockers, nitrates and oxygen are there, and unfractionated heparin, low molecular heparin, ASA are there throughout. Dual antiplatelet only from here, triple antiplatelet only from here. That means if the score is around 5 or more, you go triple antiplatelet. If it is score is around 4 or more, or 3.5 or 4, then it is dual antiplatelet. Irrespective of the score, everyone should get the beta blockers, nitrates, oxygen, and these. Now, summary of the US unstable angina or NST. We have done several slides. Now we are going to summarize that. How it is to summarize. Number 1, plaque rupture, non-occlusive thrombus. Occlusive thrombus means STMI. This is non-occlusive thrombus. It is rupture because already I got the enzymes positive and STMI. History, physical, ECG, drop. ASA, clopidogrel, unfractionated heparin, nitrates, beta blocker, G2B3A inhibitors. Early invasive, high risk, immediate PCI. Conservative, low risk, intermediate risk, conservative can be opted. Long-term treatment, aspirin, ACE inhibitor, and then the A1C control. And then the aspirin, ACE inhibitor, and then the anticoagulant wave. A is that atorvastatin. That is statin, beta blockers, and risk factor control. Okay, now this is the sum. I finished the algorithm for unstable angina, and then this. Now we have the management of the STEMI. So we will see a few slides on this. History, STEMI diagnosis, history and physical, ECG monitoring, drop, if negative, repeat it, and eligibility for lysis, you have to see anatomical location. Is it anterior wall myocardial infarction or inferior wall? Any complications are there, particularly MR and heart failure. Consider PCI as the most important treatment. Today, for STMI, treatment with primary coronary intervention is the rule. If not feasible in the center, or if they have no facilities or they are not building, then they have to go thrombolysis. Now, recommendation timeline. Symptoms onset to emergency medical service, 5 minutes. Arrival in emergency medical service, to ER assessment 10 minutes. ER to take history, physical and ECG 10 minutes. Then STMI for revascularization immediately you should go. PCI door to needle 90 minutes. Lysis means 30 minutes. So from the time of symptoms to PCI, 90 minutes is the golden hour. I had my co-brother, I told you earlier also, we were at the breakfast table and he suddenly complained of chest pain. He was a mild diabetic hypertensive, very stressed person. Like I have ECG at home. I gave him immediately when he is complaining of this chest pain, immediately I gave him 325 milligrams of aspirin, took the ECG. ECG showed ST elevation myocardial infarction. Immediately brought here in maybe 10 minutes from with all that. Here we did the drop. Anyway, drop is not required because already ST elevation is there. And immediately Dr. Pradeep was available on call and he came in another 10-15 minutes. By the time we put the needle and perfused it, 65 minutes, within 65 minutes, we could complete the perfusion. Entire ECG changes have just like that. And he is still surviving, very happy. This is a story of a person who is having the nearness to the hospital, willingness and also availability. Now the T wave changes, you see here this T wave is pulled up, then T wave is very hyperacute, then ST elevation, then followed by ST is returning to normal, T inversion is taking place, ST has almost become normal, Q waves have appeared already, and then finally STT changes have disappeared after a year or so, and the old myocardial infarction evidence the Q waves only are there. Okay. What is a normal Q wave? Normally, the impulse goes from the left to the right. That's why it produces a Q wave in the normal ECG. It is seen as a small normal Q wave in lead 1. It is less than 2 millimeters and it is less than 0.04 seconds in its width. So normal Q wave in lead 1, septal depolarization, and this is less than 25% of the amplitude of the R wave, less than 3 millimeters in height, less than 0.04. Usually it will be seen in L1, V5 and V6. This is not pathological Q. This is normal Q. What is pathological Q wave? Pathological Q wave when there is an infarction. The black area is infarction. Next one is ischemia. And then the perfusion is less. And you can see that is a deep Q waves are there. Okay. Deep, wide Q waves suggestive of infarction there. These are pathological Q waves. Okay. What are the causes of what is pathological Q wave? A Q wave infarction deep in amplitude, more than 25% of the succeeding R wave or more than 4 millimeters. Duration is more than 0.04. That is one small box. More than that, it is seen in leads facing the infarcted muscle. And not only in L1, it could be in any one of the chest leads due to loss of electrical activity due to infarction. Serial changes, normal ECG, ST elevation, further ST elevation, hyperacute T waves, peak T waves, then ST is returning to normal, Qs have formed, T inversion, then ST has become baseline, T inversion continue, Q waves are there, and finally ST segment may be normal and T inversion may also get corrected, Q waves are remaining. This is the serial changes of the ECG. You need to know a little bit about the coronary anatomy. So this is the right coronary artery directly coming from the aorta. Okay, it has got right ventricular branch, anterior marginal branch, posterior diagonal branches. These are the things. Sinus node artery also comes from the right coronary artery. Whereas left coronary artery, you have got it bifurcates. This is the left main here. And after that, it has got bifurcates into LAD and circumflex. LAD diagnosed the left anterior descending proximal LAD, distal LAD, anterior descending branches, first diagonal branch, second diagonal branch, like that. LCX is the left-sided thing. So heart has got 4 surfaces, anterior surface, LAD, left circumference, left circumflex, left lateral surface, LCX and partly LAD, inferior surface, RCA and LAD terminal, posterior surface, RCA and LCX. We have seen this in the ECG class. Left and right coronary arteries arise from the aorta, 2.5 millimeters at the origin, 0.5 millimeters at the end. Coronary arteries will fill only during diastole. Epicardium to endocardium. So, this is a very illustrative diagram of various infarctions. Anterior wall infarction, LAD is the culprit vessel, changes are in V1, V2, V3, V4. Lateral wall infarction, LAD is the culprit vessel or LCX, V5, V6, L1, AVL. Inferior wall infarction, this is the diaphragmatic surface or the inferior surface. Right coronary artery is the culprit, L2, L3, AVF are the leads which show it. Posterior wall infarction, which is behind the sternum, behind the heart, the posterior part, RCA and LCX are the culprit vessels. V1 and V2 are the mirror images will be seen. So a very useful diagram for myocardial infarction site, blood supply and the ECG leads. All in one go you can see in this slide. Now, this is summary of that. When the red ones are, that is L1, AVL, V5, VC, lateral circumflex artery, lateral infarction, left circumflex artery. The purple ones are L2, L3, AVF or inferior, PDR, RCA. V1, V2 are septal, V3, V4 are anterior. V1 to V4 is the anterior myocardial infarction. Now, TIMI score and STMI. Now, we have seen TIMI score for NSTMI. Now we are seeing TIMI score for STMI. Age 65 to 74, 2 points, more than 75, 3 points, diabetes, hypertension, angina, 1 point, systolic blood pressure, hypotension, 3 points, tachycardia, 2 points, KILIP class 2 to class 4, 2 points, anterior STMI or LBB, 1 point, time to reperfusion already more than 4 hours, 1 point, weight less than 67, 1 point. The thinner the individual here, the risk is higher. Add up these points, 2 plus 3, 5, 6, 9, 11, 13, 14, 15, 16. Total 16 points can be there. Depending on that, we classify them. And this is a short note. What is the differential diagnosis of ST elevation? If you see an ST elevation, a myocardial infarction is the first diagnosis. Prior MI with aneurysm, aortic dissection with coronary involvement, pericarditis, myocarditis, LVH, aortic stenosis, LV strain, HOCM, Brugada syndrome, fringe metal angina, coronary vasospasm, early repolarization, normal variant, pulmonary embolism, and hyperkalemia. If you see ST elevation, you must consider all these things. Not only myocardial infarction, prior MI with aneurysm, aortic dissection with coronary involvement, pericarditis, myocarditis, LVH with AS or LV strain, HOCM, Brugada, fringe metal, and then early repolarization and pulmonary embolism with hyperkalemia. Now, key information in STMI. In the history, in the lab, in the record. Exact time of onset of chest pain we must know because the prognosis depends upon the time to start the treatment. DDF ST segment infarction should be known. Contraindications of PCI fibrinolysis must be assessed. Signs of cardiac failure, arrhythmias, and then the complications of MI, aortic dissection should be looked for. Lab values, CBC, basic biochemistry, PTINR, cardiac biomarker. Records, ECG, cath lab report, previous CABG report, and prior echo report for the also are important. Now, BNP, B-natriuretic peptide in acute coronary stroke. As you can see, myocardial infarction with ST, without ST, unstable angina. All the three groups, as the BNP is increasing, the higher is the risk. Particularly in ST segment elevation, BNP, larger number of BNP elevations have a poor prognosis. Now, triple markers. What are the triple markers? Drop, CRP, BNP. One marker, no marker positive, risk 1. One marker, 2 marker, 3 markers. You see, if all 3 are positive, the risk is 13 times. 13-day mortality risk is 13 times. That means you must do the triple markers. Drop I, CRP, BNP are the 3 triple markers. So what are the risk assessments we did? We did the TIMI risk score, consider alternative diagnosis for ST elevation. We also looked at we did the TIMI score first. And then after the TIMI score, we did the DD of other ST elevation reasons. And then we also did the key informations for records, labs and all. Then we did the BNP test and the prognostication based on that. Now the triple markers. And finally, we have to use the anti-anginal drugs. Probably we will start from here next time. We'll stop here and then have the anti-anginal drugs and treatment and various things. 98 slides we covered so far. That's okay. So maybe next class we may be able to close. Today we have completed almost the NSTMI and unstable angina and initial risk assessment of STEMI. With this we will stop here and maybe we continue later. Okay.